Now we are moving to the question of how to detect antibiotic resistance by new technologies, including the keyword nano. And in the clinic, we are always unhappy if we send in a sample and 3 days later we get the resistance profile of a bacterium, because then the important days have gone. And maybe we can improve on that, as we will hear now.
Okay, good. Thank you very much. Thank you for having me. So I'm Alex Sturm. I'm the chief scientist of Resistell. So we measure nanomotions. In other words, that means vibrations of cells, bacterial cells, human cells. Any cell is doing that. And we basically use this for detecting antibiotic susceptibility. And why we're doing this is obviously to be faster than growth-based phenotypic assays that are basically the workhorses in the hospitals, and they are too slow. So you see already everything I show you today will be on a single channel device. That's basically the status where we are right now for the clinical data I also will show you today. But we're already developing a multi-channel device, which then obviously can be a game changer in the hospital. Okay, so we measure nanomotions. I think in the next slide, these numbers you just saw. So we have a big problem with AMR, and it's that big. It's also rising, these numbers, right? Evolution is always triggering more resistance. Since we use antibiotics, we increase the selection pressure. So we will have more of these cases. And that affects already the choices for patient treatment. And there's a very severe cases in sepsis or bacteremia. We have this issue that we need to actually react fast to treat the patient, to not deteriorate the situation of the patient. So in sepsis cases, the AMR threat for humans is actually, I would say, the biggest and the most urgent. Here we have to make decisions fast. The situation in the hospital, and also our method will very likely not change that, is that the patient with a critical situation will be treated empirically. So only the attending physician knows from the resistance rates and on the site, basically, what antibiotic would probably work. It's like information, like other information than basically what bacterium is infecting and also what antibiotic susceptibility profile or resistance profile. The patient is basically treated empirically. So only after a while, patients basically are diagnosed with what antibiotic could work. So they know the resistance profile, and they know later on also the species identification. But this process is obviously very, very slow. So we're talking here about at least 2 days until the patient can be treated upon an informed information. So the diagnostic workflow right now is more or less the same in several hospitals. Only the times are varying. So you have blood cultures, overnight incubation. You have either directly from the blood culture or from a subculture on a plate. You will have species identification and an AST, an antibiotic susceptibility testing that basically leads to a profile what antibiotics would work. So this entire process at least takes 2 days, actually. It can take longer. Now, what we propose is this vibration test, and not a big growth-based test, that we also fit in this workflow. But after species identification, we run our device, our test, and we deliver the results in 2 to 4 hours. Okay, so what did we actually develop? So we have a device that's called the Phenotyc. I will introduce a bit more in the next couple of slides. We have a sensor. We have sample preparation kits that directly from the blood culture allows you to adhere bacteria to the sensor, and then with the Phenotyc you can measure those vibrations. On top of that, we basically developed software components. We need to be able to measure these vibrations, process this, and also interpret that. Very important here is that we have a big database where all recordings of any referenced species and resistance profile is basically recorded, and that then is basically the base for our data scientists to develop classification models. So this is basically where we are. Now these vibrations. So any bacterium, any cell performs vibrations or nanomotions. This is basically motions on the nanoscale. It's not a motility, it's just vibrations, that's in very easy terms. And that is due to metabolic activity. So as soon as a cell is active, does cellular processes, et cetera, it performs these nanomotions. And how we measure that, we attach bacteria to a cantilever. So a cantilever is a little diving board that you know from the swimming pool. One side is attached, the other side is freely swinging. And bacteria, due to their vibrations, actuate that cantilever. So the cantilever starts to deflect. Now you can interfere with the metabolism by, for example, antibiotic. You expect the cantilever to deflect less because the vibrations go down, bacteria are dying. So we have an optical readout system to measure that. So that's a concept that was developed at EPFL a decade ago, basically. So now, how do we attach these bacteria? The bacteria are sitting on this cantilever. The cantilever is just silicate. It's like an inert material. We have to functionalize the cantilever. It's positively charged. Bacteria usually have a net surface charge that is negative. They adhere to that, and they're also embedded in some agarose. So they're in a gel-like environment sitting on this cantilever. So on the right, you see a real electron microscope picture with E. coli artificially colored on this cantilever. So this is how the specimen looks like that we're going to measure. The entire sensor is submerged into culture media, so the bacteria are kept alive, basically. So we measure a sample size of roughly a few hundred bacteria. Okay, so this is how these recordings look like. These are recordings that were used to train classification models, so basically the base for machine learning, but they're also in the clinic where we basically use our models. They are the base basically for the classification. So what we have clinically right now is a 4-hour AST. Preclinically, we have it at 2 hours, and the last couple of slides I will address that. So what we do, we come from a blood culture, we attach these bacteria on the cantilevers. It's a very fast process. We measure vibrations first just in media, and then we add a cephalosporin or like a fluoroquinolone. These are the antibiotics we have in antibiotic classes we have in the study right now. So COO is a cephalosporin, is ceftriaxone, very often used, especially here in Switzerland, as a first empirical drug. And you see that the response of susceptible bacteria on the left, these are all Klebsiella isolates, all susceptible. In brackets, you see the MICs. They react differently to the drug. So you see this trend is going down. Some are going down faster than others. And for the resistant, you also see the trend it goes upwards, but not always that straightforward. So it's very important to not just look at these recordings and then say, okay, that's susceptible, it's resistant. So we need actually this process of extracting signal parameters or features from these curves, and actually also from the raw data. This is already a transformed signal to train algorithms, classification algorithms. So we know the reference phenotypes, and then we use this as an input to train models. And we are talking here about several hundred different isolates, several different hundred recordings. Okay, so this is basically the process, how we develop these algorithms before we go into the clinic. We have our sample prep coming directly from spiked blood cultures, so we can choose the isolates that we would like to measure, so different MIC, different origin, et cetera, et cetera. We perform our nanomotion recordings. Clinically, as I said, we have models trained on 4-hour recordings. Now we train on 2-hour recordings. Use this as an input for our algorithm development. We extract signal parameters. This is on a very big scale, so like we talk about 100,000 different signal parameters. We have selection algorithms to select the informative signal parameters. So we have, in the end, roughly 5 signal parameters. Usually ends up with 5 to 6 signal parameters that actually can classify nicely susceptible to resistance. So it's qualitative, it's not a quantitative model. You have a model, and you test that basically on a validation set. These are real patient samples, real blood cultures. And then you go into the clinic. Our first study we started in summer 2021, so it's now a bit more than 2 years. It's a very complex study. It's not only assessing the performance of the device or the technology, but also get some additional information from the patient. So it works with informed consent. It's a bit slow. So anyway, we have 200 patients. That was summer this year. We are now roughly 250 patients. You see the performance accuracy tells you how well we classify overall our isolates or the patient samples compared to the reference methods. And that's the VITEC2. It's an automated growth measurement system, if you want, and this diffusion assay. Sensitivity tells you how well we classify susceptible strains, specificity, how well we classify resistant strains. And we have a Klebsiella E. coli for ceftriaxone and ciprofloxacin. And we are much faster. So as I said, we train on 4 hours. The calculation of these signal parameters is fast. So the AST, it exactly takes 4 hours. The VITEC gives you results in 11 hours and Curie-Bauer in 17 hours. Second study is more or less similar. It's a bit simpler. But you see that in other hospitals, so here we actually work with 3 different sites. The other one was just in Lausanne. Now we actually work in Spain, Austria, and in Switzerland as well. And you see here also the impact. The current situation is actually quite bad for the people, 25 hours, 14 hours. In some hospitals, they work with another system. You get actually the results very late. So this is always after, so it's basically the start of the AST. So it's not even incorporating information about blood culture and the other logistics in the hospital. Okay, so now what I said, we now are 2 hours. So you see recordings here for E. coli treated, reference strain susceptible resistant with ceftazimab-avibactam. That's a quite recent drug, one of the last resort drugs. It is a cephalosporin in combination with a beta-lactamase inhibitor. So very potent. It's not supposed to be used if no other, so like a carbapenem or other cephalosporins do not work anymore, then only this one comes into play. But it is actually used already in a couple of, and especially for Klebsiella, it is a big issue. Here we use this method. Here I actually show you some data how such a model looks like. It's a small model. The models in the clinic are much bigger, trained on a bigger data set. This is not yet in the clinic, but it is basically E. coli, Klebsiella training algorithm results treated with this ceftazimab-avibactam in our diagnostic device. So you see on the left the MIC distribution of the isolates that we tested from blood cultures. So we have quite a diverse set. And then on the right, you see from the training, we assign basically scores to every single recording. And the positive score means it's susceptible, a negative score means resistant. And you see that we compare that to MIC methods, or like an E-test or something like this. And you see that we actually perform quite nicely. So we have a few false negatives. So these are the ones in green, white on the green background, and one false positive on the right. So then we tested this. For simplicity, I only show you the table. So we have number of recordings, 118 recordings we actually use for training, also for cross-validation, and then we tested that on an independent data set. So different strains, different experiments, and you see that the performance is also quite nicely. So the first one, the training performance is 95.8% accuracy, and on this independent data set, also basically comprised of E. coli and Klebsiella, we basically have a 93% accuracy. So it's working quite nicely model. So again, this is on 2 hours. So after 2 hours in the clinic, if we bring it to the clinic, then we basically would have the result. Similar performance we have with Sulfitocol, it was mentioned before, it's one of the other last resort drugs, should not be used without an AST result. So all these drugs only should be used with AST results. So yeah, so I'm almost finished. So we are now in the step that we want to develop our single-channel device to a multi-channel device. So we think of a modular approach so that it basically can address the needs of different hospital sites, and basically give results in 2 hours. So that's the idea. We are developing this right now. We're also talking with industry partners right now. This is the team. So we are roughly 30 people. We started out with actually I wasn't there at the beginning. So Danuta is the CEO. So she started out with, I think, two engineers. Then we got some microbiologists. Now we actually work quite nicely together, engineers and microbiologists, with data scientists, and obviously scientific advisory board. So we also have key opinion leaders in our scientific advisory board. Okay, that's it. Thank you very much for your attention.
Thank you very much. I think that is the most important progress and development in the field. One of your competitors will probably be rapid genomic analysis of bacteria to find out about metabolic pathways that lead to resistance. Well, what is your view there?
So they are basically employed in the hospitals right now, genetic tests. Usually they are PCR tests. But they're usually only functional or they only lead to actionable results for escalating the situation. So when you detect the carbapenemase or you detect the cephalosporinase, then you know that you cannot use carbapenems or you should not use the cephalosporin, and you can escalate to colistin or one of these drugs that I was speaking of. But in the hospital, at the moment at least, they are not comfortable to de-escalate. So actually the purpose on AMR, curbing AMR, is to de-escalate, to use less last resort antibiotics so that we can use them longer. So in that regard, the genetic tools are at least not yet, and I also don't see it in the foreseeable future, really employed in the hospital.
Okay.
So they really want phenotypic assays.
from the viewpoint of physics, your technology goes back to the atomic force microscope technology, which was built to measure a single atom or a single molecule. Now, what are the ultimate limits for your technology? Can you capture a single bacterium on your cantilever and then deliver a result in 10 minutes instead of having first to culture the bacteria and then to measure?
There are a lot of questions involved. We don't have the means to put a single bacterium on the cantilever, so I cannot say like what is the real limit, like how few bacteria are actually needed. We are usually, and that is quite consistent, the attachment is 45 seconds, and that time you get more than 100 bacteria almost always on it. So that's fine, that's enough if you have a few hundred bacteria, but we have not invested to basically make that attachment that you only use 100 bacteria. So we have a grant application running right now. That's something that we would like to go for, that you only need a few hundred bacteria to start your assay. So I think that's feasible, but we haven't invested in this yet. The other question was?
The ultimate limits of having capturing one bacterium and then delivering in the result in 5 or 10 minutes.
And then the other question is basically, it depends a bit like how fast an antibiotic reacts, right? So I have mentioned that we measure quite high concentrations. That's fine. With this machine learning, you can actually address with a high concentration, even if it's not the breakpoint, you basically can nicely distinguish susceptible and resistant with the clinical breakpoints, actually. But antibiotics don't act that fast, usually. So some antibiotics, like colistin, is like disrupting your membrane. You see that very nicely. Others, like fluoroquinolones, they don't really destroy the cells. The cell is just basically not functioning anymore, but it's still functioning. I mean, it's still vibrating. It's still. So I think here are the limit. We're testing our limits. So these 2 hours are now with 37 degrees. So they are more active. We will see how far we can go down, right? But I think 10 minutes is maybe a little bit too short. Let's maybe 1 hour. Or
we always need to.
Of course. Yeah. You want to have
Are there other
you want to look
questions
at it.
or comments?